Good morning. I am Dr. Ajay Singh Thakur, Associate Professor, Department of Orthopedics, Index Medical College. Today we will discuss arthritis and related disorders in today's lecture. So the aim of this lecture is, at the end of the lecture, you should know what are the types of arthritis, what are the symptoms of arthritis, what are the signs, and what are the treatment of arthritis and related disorders. So fairly long topic. Should start. Some of the common types of arthritis. Arthritis, as you all know, it's what is it? It's an inflammatory disorder of joint. It can be a rheumatoid arthritis or osteoarthritis, or there are other variants of arthritis which are known as seronegative arthritis, like spond or ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and enteropathic arthritis. And there are certain other forms of crystal arthritis like gout. Firstly, to understand arthritis, you should know the ABCD of arthritis. That is the ABCD of joint. So a healthy joint should should have a proper alignment. B stands for proper bone mineralization. C stands for cartilage space, D distribution, and S for the soft tissue condition of the joint. So the normal joint is composed of, as we all know, it has what are the components of joint. Firstly, there are two bone ends which are involved, connected. In a joint, there are different varieties of joint. This is joint space. There's a cartilage covering the bone, which we call as articular cartilage. And there is something called subchondral bone, which is the bone just below the cartilage. It's called a subchondral bone. Then there is a synovial membrane or the synovial lining, or the capsule, which commonly known as capsule, the synovial joints. There's a synovial fluid for lubrication. And the normal anatomy has a joint space, which is very, very important when we discuss the joint. So in the normal joint, the joint space is well maintained, and whenever a diseased joint, the first thing to get affected is the joint space. Now coming back to osteoarthritis. So osteoarthritis, we should understand, is a dynamic disease. There is a degeneration and regeneration going side by side. So osteoarthritis, as per definition, is a chronic joint disorder in which there is progressive softening and disintegration of articular cartilage accompanied by new growth of cartilage and bone at the joint margins, plus osteophyte and associated capsular fibrosis. Osteoarthritis can be simply classified as primary or secondary. Primary or idiopathic, it's more of an aging process. And secondary, it can often because of infections of joint, dysplasia, whenever dysplasia, development dysplasia, or disease like Perthes, slipped capital femoral arthritis, femoral epiphysis, direct trauma to the joint itself, periarticular fractures, and obviously when there is a loss of blood supply, which is commonly known as avascular necrosis. So osteoarthritis is one condition which affects almost 100% of population. But what are the factors associated? It can be genetic, it can be metabolic disease, which can predispose an individual to osteoarthritis, like diabetes or vitamin D deficiency. It can be hormonal imbalances like Cushing syndromes, or there can be a faulty mechanical alignment of joint itself, like genu valgum or varus. And aging, of course, we all have to go through aging. Aging is there. So osteoarthritis, you should remember, is a disease of old age. So what is the mechanism? Always remember there's a disparity between the stress applied to articular cartilage and strength of the articular cartilage. What do you understand by that? The articular cartilage is designed in such a way to take a lot of stress whenever you walk, whenever you jump, whenever you climb stairs. The stress is generated across the knee joint. So who takes all the stress? The articular cartilage because of its resilient nature. But as in osteoarthritis, this articular cartilage weakens, so does it capacity to take this stress. So what happens is the weakened cartilage cannot take the stress further. So they start disintegrating. So they can be increased load on the cartilage when a normal cartilage cannot take this load in overweight or patients with who have very high body mass index. Or normal cartilage can also when there is stress concentration like happens in condition like varus knee deformity or genu varus or a dysplastic hip. So what are the mechanisms which cause osteoarthritis? Definitely there's a cartilage injury. So with age the cartilage becomes weak. What do you mean by weak cartilage? The cartilage, you should remember, is a very resilient structure. So weakenings will cause stiffness of cartilage or, for example, in condition like on pronosis, there can be associated soft tissue inflammation condition. And there can be abnormal bony support. See, in condition like avascular necrosis, there is necrosis of the bone beneath the cartilage. But what happens because of this necrosis of bone? There is a destruction of subchondral bone, which leads to weakness of the cartilage. And it is the cartilage when it gets destroyed, the pain occurs. So a weak cartilage undergoes some biochemical changes, which are like there is a decreased water content, the hydration, the permeability of the cartilage decreases. There is a decreased proteoglycan content. See, there is a continuous proteoglycan synthesis. With age, what happens? The capacity to body to produce this proteoglycan, which are the compounds of proteins and glucose, their production decreases with time, with age. There's changes in the chondroitin sulfate concentration, which are decreased. There's a chondroitin 4 sulfate concentration which decreases with age. Is something called keratin sulfate. What happens? Its concentration also decreases in the cartilage. Then chondrocyte decreases in size as well as number. And there is certainly decrease in modulus of elasticity. What do you understand by modulus of elasticity? It is the resistance of the tissue which to a change. So when the modulus of elasticity decreases, what happens? Shape of cartilage can change with a combined with an abnormal load. See, this shape changes permanently as it happens in overweight and old age patients. So how does it present? Patient obviously present with a simple complaint of pain, but what do you see on the X-rays? Why is the X-ray or suppose you patient comes to you with a knee pain and you suspect there's osteoarthritis? What you'll do? How will you evaluate after a clinical examination? X-rays are almost mandatory in such cases. So what you will see in the X-rays is joint space narrowing, osteophytes, subchondral cyst, and there can be subchondral sclerosis. So always get a standing view of the knee joint to see the narrowing of the joint spaces. Now further, there are some soft tissue changes. There can be weakening of the tendons and ligaments which hold the joint together, which can result in joint subluxation. Obviously, can be a deformity in the joint itself. But where does the deformity occurs? It happens in the articular cartilage first, and because of the wear and tear of the cartilage, followed by the wear and tear of the subchondral bone, there is a decrease of joint space, which can lead to a permanent deformity. For example, in knee, the varus deformity is more common, but in case of rheumatoid arthritis, there can be a valgus deformity also. So you have to be careful while evaluating whether you are seeing a medial compartmental arthritis or a lateral compartment or a tricompartmental arthritis. There can be osteophytes, marginal osteophytes, which you have to see the margins of the X-ray. And sometimes these osteophytes may break, or some of the fragments of the cartilage may break. And always remember there is a healing process going on side by side, so there can be intra-articular loose body. What changes you will see in the subchondral bone? There will be increased sclerosis, which will appear as increased whitening in the X-ray. The subchondral bone, not the joint. It has to be the subchondral bone. And of course, in the subchondral bone, whenever the joint fluid seeps into the damaged cartilage, the cracks or fissures in the cartilage, it creates a cyst in the subchondral bone, which appears as a radiolucent shadow in the X-ray. Now coming to the individual joints, first coming to the hip, as orthopedic surgeon, it's our favorite joint. So any deformity of the hip, like coxa vara, coxa magna, can lead to a osteoarthritis in later stages, or even in normal joint because of the wear and tear, or increased body weight. Whenever there is increased stress, there can be osteoarthritis of the hip joint itself. Or there can be secondary osteoarthritis in the hip because of the trauma, most common, followed by the inflammatory conditions. So what happens in the hip joint? Yes, there's destruction of cartilage, there's destruction of joint space. You will see the osteophytes, you can see the loose body. But because of the soft tissue changes, what happens? It is the superior and medial migration. So the joint space will be reduced superiorly and medially, or both. In advanced stages, the head itself, because of the destruction of the subchondral bone, may appear deformed, and there can be changes in the acetabulum because of abnormal wear and tear of the joint. Now coming to the other joint, nowadays, as you all know, knee replacement is a fairly commonly done procedure. Why? Because knee joint is more commonly prone to arthritis than hip. Why? Because it's a larger joint. There's a more surface area. There's a more cartilage. So obviously, when there's increase in weight or increased stress, I can say, or when because of disease there's a decreased damage to the cartilage or because of trauma, the knee joint is more prone to arthritis. It can be unicompartmental, it can be bicompartmental, or it can be tricompartmental osteoarthritis. What you will see is, again you will see the deformity. The varus deformity is more common in knee joints, so there can be a deformity, varus deformity of the knee joint itself, which you can see clinically as well as radiologically. They can be loose bodies. Obviously, there will be subchondral cyst, sclerosis, marginal osteophytes, joint space narrowing. It all will be there accompanied by loose bodies. And there is something called patellar tooth sign. What is that? That is irregular anterior patellar surface, which you can see on the lateral view, the X-ray. Now, the stages of knee osteoarthritis, it can be divided into 4 stages. Stage 1 to 4. Stage 4 is very advanced stage when there is complete destruction of the joint. Joint is completely destroyed. There is no joint space left. It's called stage 4. Stage 3 is fairly advanced stage, whereas there is significant destruction of joint space. You may see the lateral joint space is preserved, but the medial is gone. So that is stage 3. What will happen in stage 4? Both the joint spaces will be gone completely. So that you how you define the stage 3. It is advanced stage, but involving usually one compartment more than the other. But in stage 4, yes, there is complete destruction of both medial and lateral compartments. In stage 2, there is a significant reduction in joint space, both in medial and lateral compartment, but still some joint space will be preserved. And in stage 1, it is very, very early changes. There is some slight reduction in joint space may present in the early stages. Now, can other joints can get arthritis apart from hip and knee? Yes, there can be osteoarthritis of foot, more commonly involving the grade 2 PIP joint. So the changes will be similar radiologically, decreased joint space, marginal osteophytes, what you'll see in the X-ray. Now, same thing happens in the fingers and hand, but other joints which can be involved, yes, the spine. So in spine it's slightly different. There's something called vacuum phenomena. This decreased disc spaces and it will be uniform throughout. There can be accumulation of nitrogen inside the tissue. Obviously, the etiology is degenerative, but it is better appreciated in extension. But before labeling it simple osteoarthritis of spine, kindly exclude, is there any infectious pathology? Firstly, rule out the infectious pathology, then you think of a degenerative condition. Now, how will the patient present in all these conditions? The chief complaint will be the pain. Pain, you have to evaluate whether the pain is at sitting or resting, or it appears when the patient starts walking a certain distance, like say 500 meters or after that. So you can judge whether it is affecting his functions or not. Yes, any pain. Suppose a person is supposed to walk long distance, suppose he's a postman in a rural area and he complains of pain after walking 5 kilometers. So you'll say, okay, he's walking 5 kilometers, so what? It may be early arthritis, but you have to always consider, is it the pain affecting his function, lifestyle, job, or anything? So pain can be a chief complaint, but how the patient is affected because of the pain, you have to evaluate that. There can be deformity. Patient may complain of deformity at later stages. Or there can be loss of function. Patient will say, okay, doctor, I was a golf player, but not now. I'm avoiding golf because of my knee pain. So this is a loss of example of a loss of function. So how will you evaluate X-ray? You will get the X-rays done. That I already explained. What you look for in the X-rays. You can also get MRI. MRI gives you a clear picture of the condition of cartilage and more importantly, the condition of the soft tissue, whether there is degeneration of ligaments, meniscus, Or most importantly, MRI will rule out most of the secondary etiology, most of the infectious etiology, which you will like to consider before going for a joint replacement surgery. Now, coming to the treatment part, the treatment of osteoarthritis can be conservative as well as operative. So, what is the conservative treatment? Firstly, it is a lifestyle modification. You can ask patient to avoid the strenuous activity like walking long distances, running, jumping, etc. And you can just basically ask the patient to modify the lifestyle. If he is unwilling, like say, if the patient is a professional golfer and he is unwilling, so in that case, you may consider early surgery for them. Now there can be conservative treatment. First, the patient is complaining of pain, so you have to give some pain relief, some analgesics. You can give some visco supplementation. Lot of products are available in market of visco supplementation. Basically, glucosamine. It works. It works in early stages. But will it work when the cartilage is completely destroyed? Visco supplementation will only work when there is some cartilage left. So it is good for early stages, but not that for advanced stages. Hence, the staging of arthritis is necessary before planning a treatment. You can give intra-articular visco supplementation also. There are a lot of products available in market. Basically, hyaluronic acid and all you can inject. This also works in well in early stages. Sometimes you see in advanced arthritis, most of the patients they are unwilling. So what do you do? You know that conservative treatment is not going to work, but the patient is unwilling for joint replacement or maybe unfit for joint replacement or there is some absolute contraindication for joint replacement. What will do in such cases? You will advise, you can give always give walking aids like walking stick, walker. See, remember you have to keep the patient mobile. That is the principle of orthopedics. That is what we do as orthopedics. Yes, you can take help of physiotherapist. There are a lot of physiotherapy modalities available. Lot of things in physiotherapy, what your physiotherapist can do for your patient of osteoarthritis. So always consider physiotherapy because what happens in joint? Suppose the cartilage is gone, but yes, they can strengthen the muscle. You can always build up the muscle. What will the muscle building a muscle do? It will increase the blood supply, local blood supply. It will provide a better stability. So all these treatments actually you can combine, give a better result for your patient. And there are a lot of braces available in the markets which you can prescribe, knee braces. Some of them come with the inbuilt shock absorber mechanism also. You can prescribe that. So all this combination of braces, drugs, and physiotherapy, it provides good result, especially in the early stages. Even if you have a good physiotherapist, you may not, you may do away with your painkillers. So always consider a good physiotherapy plan for your patients. Now coming to the surgical part, what you can do, surgeries. First I'll enumerate, then do orthoscopic debridement of the joint, you can just remove all the debris, you can remove the osteophytes, or maybe you can repair the damaged piece of cartilage. If this, but yes, it has got a limited role. Whenever there's a localized lesion, orthoscopic, it works well. Nowadays, the cartilage replacement and all are available. You can do a chondrocyte transplantation with orthoscopy, and they all work well when there's a localized disease, but not so in, it's not very good treatment in a generalized osteoarthritis or when tri-compartment osteoarthritis. You can do osteotomies, high table osteotomy or distal femoral osteotomies in case of knee, or derotation osteotomies in case of femur. Can remove the, what they will do, they will realign the joint. They will remove the stress from a diseased part and shift it to a normal cartilage. So some of these patients, this is the basic principle of osteotomy. So patient will get eventually pain relief. That is what he or she wants. Now the surgery which is becoming more and more popular these days is joint replacement amongst the orthopedicians, amongst the patients also. More the more patients want their joints to be replaced. Why? Simply because it has got superior result even in the case of advanced osteoarthritis. Suppose a patient comes to you with stage 4 osteoarthritis, do a knee replacement. After a few months, patient will have a dramatic pain relief and actually he can go backwards to his life. He can start walking maybe in the neighborhood or maybe long distances. That depends how well the surgery goes. But yes, patient I have seen patient who are wheelchair bound, unable to walk, hardly mobile inside their house, doing very well after joint replacement surgeries. So what are the joint replacement options we have? Hip was popularized by Sir John Chandler long before he started replacing the knee. But yes, now we are doing more knees than hip. Why so? Because knee joint is more commonly affected. And what is the reason? Why knee? Why not hip? So you have to see that these are two different varieties of joint. Hip is ball and socket joint. Knee is a hinge joint. Hip has got wider range of motion with a limited area of cartilage contact. So patient can actually change his gait in case of hip and get some pain in knee, but not in knee. But these are the two fairly commonly joint fault. So the total knee replacement is, as you all know, one of the most popular surgeries these days. So what happens in knee replacement? We replace the whole joint. As per the name suggests, you all must be thinking that yes, the whole joint is replaced. But the answer is we actually it's a resurfacing surgery. We only replace the damaged cartilage by a metal part. There are three components in that: tibial component, the femoral component, and a poly. So, as the name suggests, tibial component is replaces the tibial cartilage, the femoral components replaces the femoral cartilage. Now, what about the movement? Whenever there is movement, there has to be some friction. So, metal on metal, the surfaces both are metal. If they move on each other, there will be more friction, more damage to the metal on metal surfaces. So, how we avoid that? We insert a poly between two metal pieces, between the tibial component and the femoral component, and it actually works very well. Nowadays, use highly cross-linked poly. Wear and tear will be there. Some wear and tear is as a thumb rule will be there, but highly cross-linked poly resist the wear and tear. So you have to be familiar with the term what is highly cross-linked poly whenever you are advising a joint replacement to one patient. You have to consider what the components of joint replacement. Yes, there is surgery involved, but yes, apart from surgery, there is an implant involved in these cases. So implant has to be of good quality. Why of good quality? Because a good quality implant will last longer, will provide more productive years to your patient. There will be less wear and tear. Now, this separate lecture will be taken of the joint replacement, but I'll just enumerate the other most commonly joint replaced is hip joint. So there's very interesting joint, the hip, very popular among the orthopedic surgeons. Whenever we talk of hip, we can talk for hours. No. But since the time is short, I'll just close up that what are the components of hip joint. So there's a acetabular component, there's a polyliner, and there's a femoral insert. These are the major components. So what does it do? So we move the acetabular cartilage and replace it with acetabular component. But to fit in the prosthesis, what we have to do? We have to take a femoral cut. We have to remove the neck and head, some part of neck and head, and replace it with a femoral insert. So, but the hip is a ball and socket joint. So you need a head over a femoral insert. So that is called a head, which varies in size according to the size of the acetabulum shell. And yes, but again, if the head is of metal and acetabular component is of metal, there will be more friction. To avoid that, what we use a poly component, a highly cross-linked poly also inside the hip, which is called shell. So what it does, it creates a fairly wide and highly mobile hip joint with, obviously there's pain will be gone after this surgery. Because where was the pain coming from? It was coming from damaged cartilage. Now you have replaced the damaged cartilage with a artificial part. So artificial part is not going to hurt the patient. But yes, whenever doing a hip or knee replacement, alignment has to be perfect. When I mean perfect, it has to be perfect. Because same thing happens whenever there are malaligned components involved, there is increased chances of wear and tear. So whenever doing a hip or a knee, what you want to give a new hip or new knee to the patient, which will last longer. And it has been documented that well done orthoplasties have last longer than 25 years. That should be your aim. So it can only be achieved when you are putting a good implant in a very good position and a very stable position. And you are fixing it properly either with cement or sometimes you do a uncemented procedure, but you have to fix it properly. It has to be properly seated and the bone and implant contact must be good. We will take another lecture on this hip orthoplasty and knee orthoplasty. It's my favorite topic. I want to, but as the time is short, I have to cut my lecture. If there are any questions, you can contact. Thank you.